So I'm just going to give folks a minute or two. I can see people joining pretty quickly before we get started. Hi, everybody. So I'm going to give everyone another minute or two to join before we get started. So if you could just hang tight for a minute. So I can hear, I was able to hear that interpretation. I'm not sure why.
Same.
Okay. Okay, great. So we're very excited to be able to offer language interpretation when it's requested. Sometimes it takes a little bit of remembering on my end how to manage it all because we don't offer it very often. Thankfully, our language interpreters are much better at this than I am. Okay, so I will go ahead and get started because we do have quite a few housekeeping notes to go through. And just as a reminder, there are notes on how to select your interpretation channel in the chat. The chat should be visible to everyone. We have instructions for English, Portuguese, Spanish, and Italian, which are the languages that were requested for the webinar tonight or this morning, depending on where you are. So I'll go ahead and introduce myself and we can get started. So my name is Blair Stone Schneider, and I'm the executive director of Sophie's Hope Foundation Cure GSD1b. I'm a 1B parent and patient advocate. Tonight we also have Margot Lafreniere, who is co-founder of Sophie's Hope Foundation, on the webinar as well. So thank you, Margot, for taking the time to be on tonight, or this morning, tonight, today, wherever you are. I'm in Europe, so it's tonight for me. I know it's early morning for people on the Pacific coast of the US and then everywhere in between. So if I keep saying tonight, forgive me. So Sophie's Hope Foundation started these webinars as a way to provide disease-specific information to the global GSD1b community from experts in the field of GSD. Our first three webinars were on IMPA or Jardiance therapy, diet, and sick day management, and you will find all of those on the Sophie's Hope Foundation YouTube page. Today's webinar will also be placed there in the next 24 hours or so. You should be able to find that there as well and be able to refer back to it. Registered for the webinar today, we have patients and caregivers mostly from 15 different countries. And we also have a few physicians and researchers registered as well. So we're glad to have all of you on. Today's format is a 90-minute webinar. The presentation is based on questions that we gathered from the GSD1b community on liver transplant in GSD1b. If there's time at the end, it may be possible to take some questions from the chat. We'll just see how we're looking on time. One other important announcement that I wanted to make is that we have a very special event actually coming up next Saturday, and also on the subject of liver transplant in GSD1. Sophie's Hope Foundation Cure GSD1b has come together with Canadian filmmaker Fraser Allen Best, who is also a GSD1b patient himself. He has created an amazing documentary that walks the viewer through his life with GSD and liver transplant. which took place during the pandemic years in Canada. It's a really, really moving documentary. My daughter, who's a GSD1b patient also, and myself had the privilege of being advanced screeners for the film. And we are super honored that Fraser is allowing the larger GSD community to screen the film for free. So that is going to be taking place next Saturday on November 1st. And Margot is uploading the information on that. There's an informational flyer that has a QR code where you can register for that, and then also the trailer for the film, which I really recommend everybody see. It's really good. And once you see the trailer, you'll definitely want to come and join the screening on November 1st. How that's going to work is that we'll have an intro on Zoom similar to this, and then Fraser will share the link to watch the documentary. It's about an hour and 45 minutes. So we'll have about a 2-hour window to watch the documentary, and then we'll all come back together for a live question and answer session with Fraser about his experience, his personal journey with GSD and liver transplant. So we're super excited about that. We hope you can make it. Looks like we're good in the chat. So please refer to that to register and to watch the trailer. So all the housekeeping notes aside, without further ado, our expert today is Dr. Monika Williams, and Dr. Williams is an assistant professor of genetics and metabolism at the University of North Carolina, Chapel Hill. That's in the United States. Dr. Williams is not only an experienced physician and expert in the field of GSD, but she is also a GSD1a patient herself. So she brings a level of knowledge on a professional and a personal level that we're really grateful for, and we're really glad that she was willing to present on this really important topic of liver transplant in GSD1b for us tonight. So with that, Dr. Monika, I'll turn it over to you.
Thank you so much, Blair. I am very grateful that I have the opportunity to speak to you all about the liver transplant and glycogen storage disease, specifically type 1b. We're going to have a couple of remarks on the transplant and GSD type 1 in general, and sometimes even about liver transplant and many other liver GSDs, but we'll point it out during the presentation. I'm very excited to do this presentation during the GSD Awareness Week, which is a really great honor to me. So thank you, Sophie's Hope Foundation and Cure GSD1b Foundation for invitation to for an invitation for me to present today. I also have a few disclaimers. I don't have any conflict of interest to disclose, but a few important notes before we dive into the topic. I wanted to share, first of all, that I am not a surgeon and I am not a gastroenterologist or liver doctor or hepatologist. So if there are any specific questions on those specific topics that only those specialties can answer, I definitely defer those questions to those providers. I also wanted to say that this presentation is mostly for educational purposes, and it doesn't serve as a medical advice. So if you or your child are considering, yourself or your child are considering the liver transplantation and you're affected by GSD1b, I definitely defer the specific questions on your care to your medical team. I'm hoping that we can all branch a little bit here and share some general knowledge. I also provide some pretty broad research overview and publications that were posted on the topic. And I'm hoping that with this will help all of us to understand it a little bit more in depth. As Blair mentioned, I'm a pediatrician and I'm a geneticist. In our clinic and during my training, both in research and in clinical care, I have worked in great and amazing mentors that I'm always very grateful to. Those mentors include Dr. Weinstein, Dr. Kishnani, Dr. Rebecca Riba-Wallman, and many others that I cannot name because the presentation would take the whole hour just with naming all of them. But I'm very grateful again for my education, for my clinical and research experience as well. And I'm also going to share a little bit of my personal experience, kind of looped into the topic as well. As Blair mentioned, I have GSD1a myself, which is, as we all know, different than GSD1b, but we share some common things together as well. This presentation is mostly for the patients and the families, so I try to avoid any medical jargon. Sometimes in the citations, I do include the medical language. So if there are any unclear things, I ask Blair to definitely let me know if anything comes up in the chat to clarify either during or at the end of the presentation. I also will be putting all the references both throughout the presentation and at the end. So hopefully those can supplement the knowledge and the findings that I was able to gather. I believe that the topic of the transplantation and GSD1b in my career came up during the questions came up many years ago, but my interest sparked mostly when I was working at the Duke on the publication that is still pending, hopefully will be out soon, on the outcomes of liver transplantation and GSD1b. We presented the poster during the AGSD conference, presenting 2 patients that had liver transplant many years ago. In the publication, we're going to have another patient included in the manuscript, thanks to the work of our collaborators, and hopefully you'll be able to see that publication relatively soon. But maybe I can start with kind of more broader topic of liver transplant and metabolic disorders in general. So when we look at the data and when we look at the indications, we're able to find that inborn errors of metabolism, for short IEMs, are collectively the second most common indication for pediatric liver transplantation. And there is also a shift in the role of the liver transplantation from being a life-saving to life-improving treatment. And that publication just came out and it's hot off the press. So I think there is lots to consider and lots to take in. It is important to specify, though, that many of those conditions are, all of them or majority of them, are very different than GSD1b specifically. You could see that this publication that was published in JIMD journal in 2025, so very recently, and actually it's really confusing because the date of the publication is November, but we had the publication ahead of a print one. So you could see that they included in the publication 3 patients with GSD1a. They didn't have any with GSD1b included in this Italian publication, but there are many other disorders where the liver transplantation is life-saving, but also could be life-modifying. And I just wanted to stress out again that those disorders that are listed on this graph are very different than GSD1a or 1b, but it kind of provides us with the broader picture. And we can dive in to all the questions. I didn't say, but in the first slide, I specified that all the questions from the audience that were collected prior to this presentation are going to be marked with that little purple or pink star. So you guys could distinguish that this question came from you. So we're going to dive right into the first question, which is, what are the reasons patients would choose liver transplant or would choose the transplant? And when we look at the literature and what has been published, we could clearly see that the most common indication for the liver transplant among GSD1 patients, both GSD1a and 1b, are hepatic adenomas. an inability to achieve metabolic control despite dietary interventions, cornstarch therapy, and or continuous feeds. And GSD1 practice guidelines that were published, I believe, in 2014, so a little while ago, specifies that it should be considered for patients with multifocal growing lesions that do not regress with improved dietary regimens and who do not have the evidence of distant metastatic disease. What does that mean? Maybe we can unpack this a little bit. We're going to dive into the topic of metabolic control later on and to the topic of hepatic adenomas. But overall, it seems that patients who develop those liver lesions, which in GSD1 are most often the hepatic adenomas that are growing and cannot regress or cannot be controlled with the diet, and patients cannot achieve metabolic control despite of trying really, really hard, which I know we all do. Those patients could be considered for the liver transplantation. And that is because of the risks associated with the hepatic adenomas or instability of the metabolic control. Another reason that I think is coming up to play more recently is, in my opinion, and in the opinion of many other providers and patients, is related to the social factors. And I think that's a really, really important factor as well that cannot be dismissed. It's really hard to pinpoint that in the guidelines or do some kind of objective measurements of the social factors. But I believe that all of those should be thoroughly considered when the patients are asking about the transplant or are seeking the transplant themselves just because of what they've heard about. We recently had the great event online on the GSD1 that it was a patient-faced FDA meeting that really showed the huge burden and fear of life-threatening hypoglycemia that is very often exacerbated after some tragic events that happened in the family or in the community, which could include such tragic events as death because of the hypoglycemia. We all know that it's always a possibility, and sometimes it just cannot be brushed off, and it just plays such a significant role that families are seeking, or patients themselves are seeking the transplantation because of those reasons. We will talk about it later on as well, but it's very, very important that any patient and any family that will be undergoing a transplant evaluation will be also undergoing the psychosocial evaluation and the family dynamics and support system, and all of those reasons will most likely be considered during the evaluation process. The next two questions state, why are transplant rates higher in some countries than others? And why do some places do not offer liver transplantation for GSD1b? And that's a really, really heavy topic and a really broad question. I'm going to try to answer it at least partially. So we could see that there are posted statistics on the liver transplantation, and those are available to all the patients. Each one of you can look them up online depending on where you live, and I think that's also a really, really powerful tool. And you can, if you're considering liver transplantation, you can definitely look, or you should even look at those statistics, and possibly if there is a way, you can maybe choose the place of the transplantation based on the outcomes or statistic posted, or reconsider it, or just talk to those specific centers as well. So in USA, there are two registries and systems that I would highly recommend. The first one is UNOS and Scientific Registry of Transplant Recipients. And in Europe, I found a couple of them And you can definitely specify with your team as well if they can share more on that. So in Europe, we have European Liver Transplant Registry, and International Registry on Organ Donation and Transplantation. How do we use those resources to find more information? I did a couple of the screenshots here, so you guys could see how you can query those. In the first one, I presented liver transplants in USA by the specific state. You could see in terms of the years and the states how many liver transplants have been performed. So you could see which state performs more. Again, that probably also depends on the size of the state, etc. This one is just to show you that you can query those registries in a very different ways and just get the information you're interested in. This one is on liver transplantation by age in North Carolina in USA, and you could see they specified it by kind of 5-year gaps, and they say in which year they had how many of them. In this one, I queried liver transplantation in North Carolina by the medical center. So we could see that we have 2 medical centers that do the liver transplantation. And you can see which one has greater amount of patients and which one does more of those surgeries, etc. So on this specific slide, you could see that Duke University Hospital does much more liver transplantations than University of North Carolina, where I currently practice. And that is for adults. You can do the similar queries for the pediatrics, etc. I also wanted to show some examples for the European countries. So you could see that this works very similarly. And I'm not trained in using those systems, and it was really easy to put those queries together. And it took me literally maybe a couple minutes. So I hope that gives us some powerful tool on the statistics. They should also post the outcomes in terms of the survival rates, both for adults and children, and per specific medical center, by specific state or country. So I encourage everyone who is considering or undergoing the liver transplantation to just look through those resources just to get the greater knowledge on that. So coming back to the question, why are transplant rates higher in some countries, and why do some places do not offer liver transplantations for GSD1b? I believe that it all depends on the healthcare infrastructure, organ availability, local expertise of the teams, availability of GSD providers, availability of hepatology and transplant providers. It will be also influenced by economic resources and social and cultural differences. Some regions do not offer liver transplantation for GSD1b because of limited access to the transplant centers, prioritization of other indications, and reliance of medical management, which could be all the very valid reasons. And I don't think we should question any of those. But if you are truly interested in the transplantation, you should definitely talk to your team and discuss that. What is the evaluation for liver transplantation process like in terms of the examination, contact persons, and registration? That is another question from our audience. I tried to put together a kind of like a graph or a simplified evaluation process. And this is, again, just an example because I am not part of the liver transplantation team. So we should be aware that this might change and might be a little bit different in each of the transplant evaluation places. So it all starts with the patient referral, and the team does the initial assessment of the patient. And the assessment includes more in-depth, lots of laboratory studies, heart evaluation, imaging studies, gut and gastrointestinal evaluation, and then, as we mentioned, the psychosocial assessment. And when we have all that data combined together, the team sits together and decides if that patient is a candidate for the transplant or not. If the patient is a candidate for transplant, then they calculate the MELD. We'll talk about MELD in a second. Or there's another system, scoring system in pediatric population. And then based on that, they're added to the wait list if the transplant of the deceased donor is considered. If the patient is not a candidate, then the team decides on the alternative care or optimization of the medical treatment. And sometimes that candidacy can change over time. Sometimes patient could be not a candidate in the beginning. There are a couple of things that they need to readdress or treat medically or surgically, and then the patient becomes a candidate later on. And it could also be reversed. Sometimes someone could be a candidate, but then during the waiting process, they no longer are. And those are all the important things to remember. What is the organ donation process looking like? Examinations, contact persons, and registration. You could see that this slide is a little bit more dense, and that's actually on purpose. Again, this is just an example, but I wanted to illustrate that if you want to be a living donor, in terms of, for example, a parent to the kid with GSD1b, or there are many other instances, you as the donor will undergo even more thorough evaluation, just because the centers and the medical teams care very, very much about the donors. They don't want any bad outcomes or any, they don't want to put the donors at any on any risk. There is always a risk associated with such a big surgery, but they want to really, really protect the donors. So if there are any questions or any hesitation, they most likely would not be considered. But again, this is such a big process, such a comprehensive process that donor will be undergoing prior to deliver donation. You could see that I also included here things such as the ABO blood group compatibility, which is very important in matching the donors with the recipients, and also a graft size assessment, which means in lay language, we have to see if the liver of the donor or that part of the liver of the donor would be compatible, would fit the body of the recipient. So for example, if the liver of the donor is too big or too small and it wouldn't fit, that would not be a good matching pair. And also wanted to stress out that there is always an independent donor advocate review, just to make sure that there is no any kind of coercion or any kind of hidden interest of the organ donation, which is very, very important in the process as well. And we could also see again this psychosocial assessment that is a big part of the evaluation. I mentioned that we're going to talk briefly about the scoring system. So in adults, we very often use MELD score, which is a model for end-stage liver disease. And that score is based on the total serum bilirubin and creatinine concentrations, which are just some of the lab values that are gathered during the assessment of the liver transplantation of the patient. And the marker that is called INR, which is one of the clotting markers or one of the platelet markers, and that is really dependent on the liver function tests as well. MELD score ranges from 0 to 40. It's an assigned number, and that number can also change while the patient is on the waiting list. That score assesses the individual's mortality risk from liver disease and its complications during the next 90 days. So if we break it down to the, again, lay language, it basically tells us how sick the patient is and what's the risk of death for that patient, of the death and the complications from the liver disease over the next 90 days. It might sound a little cruel and brutal, but it kind of provides an objective, in most of the cases, objective measurement on how to place the patients on the waiting list. And that is mostly for the deceased liver donor donation or liver donor transplantation. We could see that the higher the score is, the more severe the disease is. We could see that in GSD1 patients, that score could be really, really misleading because many times the functional status of the GSD1, both 1A and 1B patients, is actually pretty good. Aside from the adenomas that are often an indication for the transplantation, very often we have normal bilirubin, which means that there is no jaundice. There is very often normal creatinine concentration. There is normal clotting, or it could be disrupted because of some other issues going in with GSD1 patients. But the INR very often is just normal. So patients with GSD1 that are undergoing the transplant evaluation for the deceased liver donors often do not get such a high score and could be superseded by other patients that do not have GSD that are just going to be placed higher on the waiting list. And that could be really unfortunate because obviously we know the risks associated with the hepatic adenomas, and we'll talk about them later. But if the patient with GSD1 truly needs the liver transplant, we often advocate for something that is called MELD exception. And MELD exception in GSD1 is presence of the adenomas in GSD1 could qualify as the MELD exception, which means that the score is not as important or some additional points are added and the patient is moved higher on the list just because of the presence of the adenomas, no matter what the score of the MELD is, which gives those patients a chance. In pediatrics, we use something similar that is called PELD score, which is called end-stage liver disease score in pediatrics. And that, again, helps with the allocation of the deceased liver donors. And again, estimates the risks of death and the complications. Very often in the living donation, the centers will still calculate the MELD scores, but that is not obviously used for placing the patient on the waiting list just because we have the living donor available in those cases. So the patient doesn't need to be placed on the waiting list. So it's just used for different purposes in those cases. There were a couple important questions from the audience on the types of the liver transplantation. So maybe we can dive into that a little bit more as well. The question stated, must the liver always be fully removed to be able to implant a new live donor liver? Can a lobe of the old liver be left in the patient? The GSD1b patient apparently needs only 50% of the liver to function to be able to convert glycogen to glucose. So if one can do a partial liver transplant, one will have a backup liver if the new liver fails. Then there is still the old liver. I just wanted to clarify a little bit in that last question. Actually, there are some studies both on the animal data and on the human clinical trials that GSD1 patients, both 1A and 1B, actually need much lower enzyme activity for the liver to function normally. That percent is sometimes quoted as 5, 7, sometimes 3%. So definitely much lower than the 50%. But the question is definitely still valid. And I believe it might have come from the fact that GSD1 parents are carriers of the disease, and we know that they have 50% of the enzyme activity and their liver functions normally. So I could see why that 50% was listed there. So let's dig into the types of liver transplantation. I tried to put together a table that lists different types. We briefly mentioned already the deceased liver donor transplantation, the living donor liver transplantation. So you could see the main difference is obviously the donor type is deceased or living, and in the living donation, we always have only just a part of the liver implanted into the recipient. And then the deceased donor, most often it's the whole liver. The whole liver transplantation is the most common, but both of them are possible in GSD1b. Living donor transplantation is often a planned surgery, it's an elective surgery, and we'll talk a little bit more about the differences later on. Two types of the liver transplantation could particularly pertain to those questions asked by the audience. One called axillary partial orthotopic liver transplantation. You could see that that includes a partial liver, and very common, it's used in acute liver failure and sometimes in metabolic disorders. We will talk about it on the next slides as well. I also wanted to put a domino liver transplantation that is sometimes used in other than GSD1 metabolic conditions, where the liver is taken from the patient with the metabolic disorder and is implanted to another healthy patient, or not healthy, but the patient that needs a liver transplant that doesn't have a disease in other organs, and that liver functions okay. That could be used in conditions like maple urine syrup disorder, but it cannot be used in GSD1b or hasn't been described before, and there is really no role of that. Just because we would expect that the GSD1b would be present in the transplanted liver in the patient that receives the liver. And there is also a hepatocyte transplantation that just includes some hepatic cells, some liver cells transplanted into the recipient, and we'll talk briefly about that as well. I find the concept of the axillary liver transplantation pretty interesting, and I tried to make a little bit of the illustration of that to help the audience understand the concept of it. Most often it's used, as we mentioned, in the fulminants of full-blown hepatic or liver failure. So really acute liver disease that is just really, really spiraling down, and it's really, really dangerous. So the patient needs the intervention as soon as possible. Otherwise, they are really at the risk of death is really, really high. So you could see that the donor left hepatic lobe, so left liver lobe, is being transplanted to the recipient liver. So you see that the donor liver is that yellowish orange color, and you could see that it's kind of sewn in and attached to the recipient liver that is initially that pinkish color on the graph here. And we know that liver cells have the possibility of kind of getting bigger and hypertrophy and kind of taking over. So you could see that in this picture, the healthy liver from the donor is kind of taking over the pink liver, so the liver of the recipient, which means that it's getting much better, and it's the liver is functioning much better. Hopefully, at some point, the goal is that ultimately this leads to the involution of the donor graft after the recipient liver heals over, and that can hopefully help with withdrawing the immunosuppression, which is definitely the goal. So you could see that in the beginning, the donor liver takes over and creates all the functions that the liver needs. And then after the recipient liver heals, that kind of takes over again, and the liver is healthy, and the donor liver diminishes, and we can take out the immunosuppression medications. That has not been previously tried in GSD1b. I was asking myself a theoretical question if that could be potentially used in GSD1b, and possibly if we had some clinical trials or approved gene therapy for GSD1b in the future, possibly that could lead to like a bridge between the medical management and the gene therapy, hopefully where we could treat with gene therapy the native, so the recipient liver, and that can hopefully over time take over the donor liver, and hopefully at that time we could take out the immunosuppression medications. But it's a very theoretical concept, and I don't think we're there yet at the medical field. And as you could see, it has not been ever published on any patients with GSD1b. I should also mention that the risk of the adenomas in the native liver in GSD1b remains pretty high. And the native liver that would regenerate if not treated with any new therapies, like gene therapy, would still have GSD1b. So I don't think that at this time that would be a good recommendation. But again, please talk to your medical team about that. I also wanted to mention the hepatocyte, so the liver cell transplantation that has been previously published in a patient with GSD1b. I also think it's a very interesting concept. Unfortunately, at this time, we do not have the mechanism of the persistent effect of the hepatocyte transplantation in GSD or other metabolic disorders as well. You could see that patient that was published, the publication was in 2007 in Korea, and there are some other patients with GSD1a that undergone liver cell transplantation. It's a very different surgery. The transplantation of the liver cells is given through some of the major blood vessels around the liver. So the surgery, again, is much different. And there is a hope whenever hepatocyte transplantation was performed that those transplanted liver cells would take over the GSD1b liver. And the transplanted cells obviously do not have GSD1b. This patient was documented up to 250 days. There was a significant metabolic improvement up to that time. However, no further data has been documented. And we know from other metabolic disorders and the publications and papers published that unfortunately that long-term benefit with the hepatocyte transplantation has not been documented, and the average duration of the effects are between 6 months to 2 years in metabolic disorders. So again, at this time, unfortunately, not the great outcomes, just because they are just so short-lived, and we do not have a lot of patients published, probably because of that. Another question from the audience: is it common when a GSD1b patient goes for a liver transplant to also have their spleen and gallbladder removed at the same surgery? Very, very important question. And even though I'm not a surgeon, I'm going to try to answer it. We know that splenectomy, so removal of the spleen, is not routinely performed during the liver transplantation. I think it also warrants a disclaimer that in the past, for the GSD1 patients, splenectomy, so that removal of the spleen, was sometimes considered when the patients with GSD1b had very large spleens, and that posed the risks for some other medical complications. Large spleens in GSD1b historically were mostly because of the high and frequent doses of the Neupogen or GCSF. So hopefully nowadays we don't see this being that common just because of the EMPA and Jardians being present. We were able to either discontinue or lower the doses of GCSF. So altogether, the spleen removal is not routinely performed. It might be recommended in some sporadic cases, which again, I would defer to your medical team, but in general, it's not the common practice. When we think about the gallbladder removal, which is called cholecystectomy, that one is routinely performed. And if we have a deceased liver donation, we often do perform the removal of the gallbladder, both in the deceased donor liver and the recipient liver. Both of those are removed, and that usually doesn't pose many complications. We actually are preventing future gallstones and complications if that gallbladder was to be left in the abdomen, in the belly. And that also, when we remove the gallbladder, that also helps during the surgical procedure overall. Sometimes it's just in the view, just in the surgical field, and complicates things. So the surgeons often do remove the gallbladder for those purposes as well. A couple questions on the long-term liver transplant outcomes. One person asked, what is the longevity of a new liver? 10 years, 25 years or more? What is the projected life expectancy in GSD1b patients who have had organ transplantation? Let's try to dig deeper into that topic. We know that there is limited data on the long-term transplant outcomes among patients with inherited metabolic disorders in general, including the liver GSD types. There are several systematic reviews, which are those larger publications. Some of the case series that just publish a couple patients, or case reports, which the publication includes one or a couple patients again, that suggest that the 5-year survival rates can reach 81 to 89% and are higher than the rates of the survival of the liver transplantation patients for those without a diagnosis of metabolic disorder, which I think really stresses out an important point. When we look at all of those statistics, I mentioned to you guys how to access those statistical data in the beginning of the presentation. We can find those 5, 10 year survival rates for the liver transplantation patient. Liver transplantation in general is often done for the patients that have a really significant liver disease. Very often those patients are really, really, really sick. And that is not always the case with metabolic disorders or with patients with GSD1b. So sometimes it's really hard to compare the survival rates of the people that had the transplant with GSD to survival rates in general. But we think that the patients with the metabolic disorders are going to have higher survival rates just because their liver disease and other complications associated with like general health are not present in GSD1b patients. I hope that makes sense. I know it's really hard, but I hope it makes sense. And we could see those quotes. I'll try to quote a couple more statistical data, and they're going to vary. I don't think either one of them are very accurate, just because it's, again, so hard to provide good statistical data for such a rare condition that GSD1b is. And if we mix in the liver transplantation into the picture, it's even more rare. And those patients would need to be followed very closely. And it's just very, very hard study to do. So again, we have those statistics, but again, they might not be very accurate. So I just wanted to make sure that we have that disclaimer. We could see the citation from two publications as well, that the first reported liver transplant for GSD1 was performed in 1982. And since then, more than 100 children had undergone the transplantation. That data is, again, a few years old now, and probably, most likely, I'm almost certain that we have much more cases reported and not reported of GSD1 patients that undergone liver transplantation. We could see that in this paper that was published in 2012, the 1, 5, and 10-year survival rates were 82, 76, and 64%, which on one hand, they are really promising, but on the other hand, I think that they're still really very scary. I'm hoping that nowadays the rates would be much higher, just because the transplant techniques have improved since 2012. But if we try to analyze those statistics, when we think about the 1-year survival rate, it says that 82% patients survive the first year, which unfortunately means that 18% of them do not make it. And when we think about 10-year survival rate, 64% survival rate means that 36% do not make it. When we compare that data with the survival rate of GSD1b that is medically treated, that does not need liver transplantation, again, I know that there are cases that definitely need it, but when we compare the patients that do not need it, I think it's really important to think about what is the survival rate, predicted survival rate without the transplantation. And you can again speak about that with your medical team, because again, every patient is different and they will all have different reasons to undergo or think about liver transplantation. Again, I want to stress out that this data was published in 2012, so we're going to have a little bit more optimistic data as we go through. We could see that there is a recent analysis that was published in 2022 of available studies among GSD liver transplant patients. Again, it was more generalized, not only 1Bs, not only GSD1s in general, but also other liver GSD types. And that post-transplant complication rate was about 25%, which means about 1/4 of the patients had complications, and 22% of those were complications related to GSD. We know that the liver transplantation heals the liver or helps with the GSD in the liver, and we'll talk about it more again. But there are still other organs affected by GSD. So that's why there are some complications even after the transplant related to GSD. There is another publication from 2024 that lists 8 patients with GSD1b specifically, that cites that despite improvements in metabolic control and normalizations of the fasting tolerance, which means that there was no longer hypoglycemia present, morbidity from infection and gastrointestinal manifestations persisted, which means that the effects of GSD that are present in the neutrophils and in the GI system still persisted after the transplant. And again, we'll talk more about that. We all know that now we have EMPA. Dapagliflozin is very similar medication to EMPA. So I'm hoping that would also change. And most likely that publication did not include a lot of patients that were on EMPA historically, just because it wasn't available. It was a very recent discovery in the field. At the time of the publication of this publication of this presentation, I mentioned that we are working on the manuscript of 3 patients. 2 of them are adults, and one of them is 14 years, and the other one is 17 years after the transplantation, which that will contribute to the long-term survival data of the patient population. Those 2 patients have GSD1b. Another publication, or actually two publications, list that 10-year patient survival rates among the liver transplantation are closer to 90 to 100%, which is much, much higher than the 64% that we were citing from 14 years ago, which gives us much more hope. We could see that there is a study published in 2020 by Japanese physicians. They transplanted 11 children with GSD1b, and their patient and graft, so a graft is the transplanted liver, survival rates were close to 90%. Again, that is very, very reassuring, but I still keep in mind those 10% that unfortunately didn't make it, which is still gives us some work to do on our end. Another single center study that followed patients for about 10 years after the transplant found that all of the patients that were transplanted survived, but about 75% of them experienced the rejection episodes, which I think it's really, really hopeful. Gives us a lot of hope to hear that all of them survived, at least the 10 years after transplant, and that 75% of the rejection rates definitely stress out the careful follow-up that needs to happen after the transplantation. And in our publication, I already mentioned that we have 2 patients that are 14 and 17 years after the transplant. So I think when we think about how to summarize it all, we can say that while the preclinical trials demonstrate the potential of the gene therapy being curative, hopefully, or providing lots of help in the management of GSD1b, unfortunately, currently, liver transplantation is the only curative, and I should put that quotation here, treatment for the liver GSD1b. However, it's also very important to stress out that it is associated with significant risks related to both liver transplantation surgical intervention itself and also the extrahepatic, so manifestations of the disease in the kidneys, in the neutrophils, and in the intestines, which hopefully can improve but are unlikely to resolve with the liver transplantation. Again, I mentioned that EMPA, the discovery of EMPA or Jardians, hopefully are going to shift that later part of the statement, and we already see the effects of that as well. What are the success rates for the liver transplant in GSD1b, and what is considered a successful liver transplant? How do we define it? I think that's a really, really good question, and I was trying to get some help from some of the AI tools as well. I kind of liked this sentence that a successful liver transplant is defined by a combination of clinical, functional, and patient-centered criteria, which the core elements being patient survival, graft survival, restoration of health, and avoidance of major complication. What are the good survival rates? It's really hard to put a specific number on that. We can say maybe good survival rate is greater than 90%. I think we should really strive to as close to 100 as possible. And then what are the long-term complications? We'll talk about that soon. Here we go. What are the general risks of the liver transplantation? I kind of divided them in a couple categories, the early, intermediate, and the late complications. In the early complications, I put all the complications associated with the surgical procedure itself. It's gonna be a really long surgery, and there the risk of complications is really high. Granted, again, that the surgical techniques are getting better, but I'm sure that when you undergo the transplant evaluation, all of those will be discussed with you. The intermediate and long-term complications are mostly associated with rejection, immunosuppression, with some of the vascular issues and drug toxicity of the immunosuppression medications. And then late complications, you can have chronic rejection, a recurrent disease, malignancy, which patients that are on immunosuppression, long-term immunosuppression, are at increased risk for cancer, and then metabolic complications and late biliary complications. So when we dig more into GSD1b specific complications, this publication just listed a couple of them, and some of them, as you could see, this publication had analyzed 210 patients with different GSD types, and there were 42 patients with GSD1b, but the complications were kind of they were not specified by the GSD types. So you could see that they very often overlap with the complications seen in general patient population. It's really reassuring also that 72.3% of the patients had no complications related to the liver transplant, or at least nothing that was published or reported in the publication. When we think about kind of like three categories, one of the categories being metabolic control, I wanted to think, how does the transplant affect the metabolic control? We know that all the patients that were published achieved the normalization of the metabolic control, including the blood sugar levels, lactic acid levels, and triglycerides. I specifically didn't mention the lactic acid or the liver function tests, which we'll talk about soon. All the patients were able to discontinue the cornstarch therapy and strict dietary restrictions associated with the GSD diet, which contributed to self-reported improved quality of care. We know that liver function tests could be intermittently elevated, like LFT or AST, and that could correlate with the rejection episodes. Few questions from the audience were pertaining to: does the transplant cure GSD1b? Does the transplant cure IBD? What changes as a result of the liver transplantation? What are the side effects? And what complications of GSD still occur afterwards? So again, I stressed out that the definition of cure, which can again vary from person to person. In simplified words, in my mind at least, the transplant cures GSD1b in the liver, but not in other organs and cells. So there is still significant risk for the kidney disease, neutrophil dysfunction, and IBD. Uric acid often remains elevated because of some of the transplant medications. And we can often see that the liver with GSD1b is transitioned to the liver after the transplantation, which sometimes could be a disease of itself. And we will talk more about the complications again. It is, therefore, in my mind, not considered a cure overall, but it definitely gets rid of the GSD1b in the liver, but again, not in the other organs or cells of the body. I think maybe it's also important to say that if the person with GSD1b had the liver transplantation, and they have children in the future, they would be still at risk for transmitting the affected genes to their children. There is more into genetics. You would still need to meet a career partner in order for the baby to have the disease, but just wanted to stress that out, that liver transplantation doesn't cure GSD in other cells beyond the liver. Is there a known case where things went wrong and blood sugar did not remain stable after the liver transplantation and was still worse or unchanged afterwards? I am not aware of such a situation. I cannot swear upon it, but I am not aware of it, and there is no publication posted that I was able to find with my extensive research that could document that. So the expectation is that the liver transplantation will help stabilize or normalize the blood sugar, and there are no published cases of persistent or worsened hypoglycemia after the transplant. Once the transplant is performed, can they have a normal diet? Will they need cornstarch? Are recipients told that they need to stay on the same diet after transplantation to avoid other organ tissues, like the kidneys? Again, very, very good question. So based on what we said, there is no need for sugar restrictions or carbohydrate restrictions after the transplant. There is no need for cornstarch. There is, though, a need for a healthy, balanced diet. And it's also important to mention that patients on immunosuppression should avoid certain foods like raw or undercooked meats, unpasteurized dairy, raw seafood, and other high-risk foods like deli meats or soft cheeses, unwashed produce. And that is most important right after the transplant. Could improve after the time passes, but again, that would be something you would discuss with your transplant team as the time passes. It's also important to remember about the strict environmental hygiene, like hand hygiene, proper food storage, and thorough cooking, just to decrease the infection risk. So we mentioned that in the outcomes, we mentioned the metabolic control. Now we're going to focus a little bit about the neutropenia and neutrophil dysfunction. Is the liver transplant more risky in 1B other than 1A, or is it equivalent because of the EMPA? Are neutrophils within the normal range after the liver transplantation? Well, you still have neutropenia after this transplant, and how is it managed? So we mentioned already that the neutrophil dysfunction is not cured with the liver transplant. It can sometimes get better, but unfortunately, it would not be cured. Moreover, the immunomodulation or immunosuppression that is required after the transplant increases the infection risks. So the question is really, really valid if the immunosuppression is more risky in GSD1b. In our cohort of 3 patients that we're working on publishing, both of our adult patients continued to experience frequent infections. They were not as frequent as prior to the transplant, but they were still present, and there was intermittent neutropenia, and they required continued GCSF. Granted, that was all before the EMPA. Now, we expect that the EMPA would definitely be helpful even after the patients have had liver transplant. There are publications on that as well. And you could see the references here. The patient number 3 that is going to be included in our manuscript suffered a severe viral infection, but had no other severe infections after the transplantation. And then we can think about IBD, just because it's so closely related to the neutrophil function. In our patient cohort, our patient number 2 required a subtotal colectomy, which is taking out a lot of their large colon, large intestine, just because of the severe IBD symptoms after the transplant. Again, that was before the EMPA was discovered and repurposed for the population. We suspect that in the current era, when the patients are required to be on EMPA after the transplant, the GCSF might not be needed. The EMPA just provided such a big shift in the GSD1b population that it's really impressive, and it's important to stress its role even after the liver transplantation. I think our publication also made me realize that the patients after the transplant are often no longer followed by the metabolic centers. And when you ask a typical liver transplant doctor if they ever heard about the Jardians or EMPA, they would be really unlikely to make the connections between Jardians and GSD1b just because of how rare GSD1b is. So it's important if you ever had the liver transplantation many years ago, or even recently, just to check in with your metabolic team once in a while, every couple of years, just to check if there are any new discoveries. If you had never been on EMPA before and you had the transplantation many years ago, and you struggle with the neutrophil dysfunction or IBD, maybe it's worth also to reach out to them and ask about it. With GSD1b, is there a higher risk for rejection? And how do you manage anti-rejection medicine with neutropenia? Prior to Jardians, the rejection rate could reach about 75%, which is really high. And it's much higher, it's doubled or even higher than doubled when we compare patients without GSD1b. With EMPA, we don't have new statistics, but it's definitely going to be much lower. It's important to mention that early rejection might be underdiagnosed in GSD1b due to the atypical presentation and reduced inflammatory markers in neutropenic patients. There is often a role in the biopsies after the transplant just to check that risk of rejection. And I put the citation here of the six females and 2 males that children with GSD1b that undergone liver transplantation. And that publication was posted in 2024. I think that the important statement is that although a reduction in unplanned hospital attendance due to the infection was observed, GI symptoms and graft dysfunction were accounting for similar hospitalization burden prior and after liver transplantation. Again, most of that was prior to the EMPA or the dapagliflozin, and now hopefully we will see more improved data, but just sharing what's available in the literature and what was published recently. Why do some places do liver and kidney transplants at the same time? Again, very important question. We should all know that there's a baseline risk for kidney disease in GSD1 with new treatments and new medications and new medical management guidelines for GSD1, including 1b. The risk for kidney disease in GSD1 is much lower now, but it still persists. And unfortunately, after the liver transplantation, the medications that are given for immunosuppression increase that risk after the transplant. So often it happens that the patients with GSD1, both 1A and 1B, that had the liver transplantation and are on immunosuppression medications, many years often after the transplant, sometimes decades after, require a second transplant, and this time it's the transplant of the kidney. We also don't know the role of the liberalized diet because we know that the kidney is still going to have the GSD1b in there. We don't know if the diet without cornstarch and without all the dietary restrictions that were previously in place, is that affecting the kidneys? It's really hard to tell. Most likely not that much, but we are not certain of that. And if there is an evidence of the significant kidney disease at the time of the liver transplant evaluation, very often those patients are offered the combined liver and kidney transplants at the same time. So that's definitely, again, one other thing that you would need to discuss with your team. Just check your kidney function test and discuss those with them. Just because we don't want to do the liver transplant and soon afterwards the kidney transplant. Again, it's possible, but if there is a significant kidney disease already present, it might be more beneficial to do all of them at once, two of the organs at once. When we think about the kidney disease and high uric acid, we know that if the liver transplant is not combined with the kidney transplant, and there is already a significant kidney disease, that those anti-rejection medicines, specifically tacrolimus or other calcineurin inhibitors, may further contribute to the kidney damage and also worsen high uric acid. Very often, the patients after the liver transplant and on those medications still require allopurinol, even if they don't have GSD1. How can liver transplant be avoided? I think that's also a very important question. I know we're running out of time soon. Whoops. Uh-oh. Can you guys still see it?
Yep, we can still see it, but I think you went ahead a slide to hepatic adenomas.
Uh-oh. All right. Sorry. All right. Thank you. Yeah. How the liver transplant can be avoided. All right. So when we go back to that question, why is liver transplant often needed or recommended in GSD1? It's most often because of those hepatic adenomas and inability to achieve metabolic control despite those dietary interventions. So when we reverse that question, when we think about how to avoid a liver transplant, we should think about maximizing metabolic control, minimizing the risks for hepatic adenomas, which often includes avoiding any estrogen exposure, like, for example, for females, avoiding the systemic contraception that includes the estrogen in it. And then again, the role of metabolic control is huge. I do understand that we all try the best we can, and I'm walking in the same shoes as you guys are. And very often, if the patient does develop an adenoma, sometimes we don't know why it happens, and the risks are much lower with the good metabolic control, but the risks still persist. And I've heard of at least a couple patients that developed the liver lesions, and their metabolic control was actually pretty good. Once the patient has developed adenomas, is the transplant the only option to treat them? Again, very good question. And I think it all depends on your specific situation and your medical team. Management of the hepatic adenomas in GSD1b includes surveillance with imaging like ultrasound or MRI every 6 months to 12 months when no lesions are present, more often when the lesions are present. We look at the growth and how those lesions are changing over time. We check if they have kind of like nice round boundaries, or if the architecture is a little bit suspicious. So the radiologist or people that interpret the imaging studies are going to be very helpful to us. There are some surgical options for the adenoma resections, including the surgical resections or injection of the ethanol around the adenoma or ablation. And we should be aware of the risks associated with the adenoma, such as bleeding and cancer. What's the likelihood of the adenomas turning into cancer? Again, very good question. And I put some statistics here to cite that. We think that when the lesions are getting bigger, that risk is estimated around 10 to 12%, which could sound low, but I think actually it's pretty high. And especially we pay very close attention to those lesions if they are greater than 5 centimeters, because both the risk of the bleeding and the risk of turning into cancer is much higher when the lesion is greater. Other studies also cite the risks as around 10%. If the lesion is small and we know that we are not able to achieve good metabolic control, we can often really strive for really getting good labs and trying the best we can again. We have documented that the adenomas can shrink, and I'm giving a little bit of the gratitude here with the orange colors to UF and the work that we've done with Dr. Weinstein's GSD team. We are able to demonstrate that the adenomas can shrink and can involute or disappear even. Again, not in everybody, but we all should try the best we can. And here I'm just citing the risks of the associated with not the risks, the rates of achieving the metabolic control and how does that correlate with developing complications such as hepatic adenomas or kidney disease. We know that once the metabolic control is achieved with proper medical management, those risks are much lower than in the past. And you could see that the hepatic adenomas are the risk for hepatic adenomas is much higher when the triglycerides are greater than 5,000. We strive for normal labs, so again, try the best you can. But the studies documented that 500 threshold as being really crucial. Next question, can the patient ever be too sick for a transplant? And the answer is unfortunately yes. Sometimes I put the contraindications for liver transplants on this slide. I think the most significant contraindication would be if there is a liver cancer detected that has spread out beyond the liver. That definitely would be an important one to discuss that could disqualify from the transplant. Definitely the infection risk. Definitely sometimes the patients could be too sick from the metabolic standpoint to undergo the transplantation. So that should be definitely fixed before the transplant occurs. And the more stable metabolically you are before the transplant, even the days prior to the transplant, the better the outcomes are, just because the body that is in metabolic control tolerates such a big surgery better than when it's not in a good control. We mentioned some bleeding risks, so that is also included. Then sometimes there are some surgical things that do prevent from the transplantation, and also those psychosocial aspects as well. I think I already spoke about that. What are the risks of the rejection and how do you avoid it? We are told that the first 12 months are the riskiest for infection or rejection. What precautions should be taken? Very important. You never miss your anti-rejection medication. That is your lifeline. You're kind of changing cornstarch and MPA to immunosuppression. MPA still obviously should persist if it's indicated. Some people would still be recommended to take the Neupogen or GCSF. So maybe I should correct myself. We're changing cornstarch to immunosuppression medications, and we should never ever miss that, because there is a clear correlation with the risks and poor compliance with the anti-rejection medication. We already spoke about the safety. And you're right that the first year after the transplant is definitely the highest risks. I put some complications of the immunosuppression medications, and we kind of briefly spoke about them before as well, but wanted to list them. That list is not extensive. When you look it up, it could take a couple slides, so I just focused on the most important ones. The general ones, again, include the susceptibility to infections, risk of malignancies, and cardiovascular disease. How many patients with 1B have already undergone the liver transplantation? This is what has been published. There are many more cases that have been performed and are not published today. You could see that there is a Japanese study that listed 11 children, UK 8 children. There's a publication by Dr. Weinstein that lists there's 6 children and patients in the US and Europe. We're working on that publication that has 3 patients, so it just contributes to the knowledge. And I included in the slides the summary of those publications just for reference. We spoke about a lot of those things already before and the other topics, but I think it's good to put them all together here. So this one summarizes the Japanese study. This one summarizes the UK study. You could see a lot of them just stress out that there is no improvement in the extrahepatic manifestations, so manifestations of GSD1b beyond the liver. And the 6
Hey,
children.
Dr. Monika,
Yeah.
just to jump in really quick, just a time check. We're at
Yeah.
about 5 minutes. So I don't know if you want to prioritize certain remaining slides. Just wanted to give you a time check there.
Thank you. Sounds good. All righty. So we'll just, I think that's a good idea to just skim through those. They will be available for you guys, and you have the citations here. What are the medications needed for the transplant? We already mentioned all of those, so I'll skip through that. What does the care look after the transplant? Again, summarizing many things that we already discussed before, just highlighting the really important weeks right after the transplant. And kind of trying to put together a slide that could represent it. Again, it's going to be varied, going to be different in each person. What's the youngest reported person that had the liver transplant with the GSD1b, and what has the outcome been? I found a publication that lists children that was a child that was 4 years of age, and then that publication that we previously cited of 8 children with GSD1b, that median age was 3.6 years of age. And our patient that will be included in our publication has been 14 months of age. It all changes with the EMPA and Jardiance use. So definitely the outcomes are much better when the EMPA is used. Can the parents be donors? Yes, they can. And that has been also documented in some studies. Just a brief reference to genetics. We know that the parents are carriers, so they only have that 50% of the enzyme activity, but it doesn't prevent them from being an acceptable donor if if they meet other criteria during the evaluation process, including the blood typing matching and some other many things as we discussed. Someone asked about the comparison between the living and the deceased donor. So again, I tried to pull some of the considerations on this slide that can distinguish between the living and the deceased kidney donor. That will be all discussed with you with your medical team. Not everybody is eligible to get the living donation. Sometimes we just need the greater volume of the liver, but sometimes it is acceptable and possible, and they have been documented cases of both deceased and the living donor transplantations in GSD1b. And again, trying to just compare both of them. I think we can skip through that. All right, in summary, I believe that post-transplant outcomes have shown significant hepatic and metabolic improvements, especially when we include the Jardiance or EMPA into the picture. We still have to remember that it's a really, really severe, not severe, it's really big surgery, has a lot of complications that we should keep in mind. The transplant evaluation and post-care post-transplant care are very intense. and that decision should not be taken lightly. But I think the outcomes are getting better. And again, it should be a very individualized decision. We should, again, prioritize metabolic control and metabolic management. However, we know that there are situations where the liver transplantation is recommended and should be considered. These are all the resources that I used, and a thank you slide. And I'm so sorry that I went so long, and I don't know if we have time for questions, but I'm happy to stay later if needed.
Thank you. That was absolutely amazing. I am so impressed with just the amount of information and data that you have been able to present in 90 minutes. It's really incredible. And I think the fact that there are very few questions in the chat is testament to that because everything was very thoroughly explained. So super grateful for that. If people do have follow-up questions, they can always email me. And you and I can connect on that and we can try and get questions answered. But I do want to remind everyone that these webinars are recorded. They will be on the Sophie's Hope Foundation YouTube page. This one will probably be up tomorrow or so, hopefully. And also a reminder about the film screening for Thanks for the Liver, which is a patient perspective on liver transplant and GSD1b in a GSD1b patient. And that you'll find that information in the chat. You can also find that information on the Instagram and Facebook pages of Sophie's Hope and Cure GSD1b. And yeah, most of all, a huge thanks to you, Dr. Monika Williams of UNC Chapel Hill, and thank you to our interpreters, and thank you to Sophie's Hope Foundation for providing this expert information to the community.
Thank you so much. It was really an absolute pleasure, and I hope we can all learn from it. I definitely learned a lot, and thank you again for you guys and all my teams and my healthcare providers and all the patients. You guys have taught me a lot over years.
We're very grateful to have you. Thank you so much. And everybody have a great evening or morning or day, whatever time it is where you are. Thank you again for all taking the time to attend.
Thank you.
Bye-bye.
Thanks, Monica.